This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker for this evening, we'd like to give an overview of our free program for those attending for the first time. So we will discuss who we are, what is our program, some upcoming events, introduce our speaker, Kelly Clancy, and then have a Q&A. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, who's also on the call, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife, Carol, who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference in Cincinnati, Ohio, to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 90 groups to date. Each group is given their own free website with a link from the directory and map. We receive feedback that conferences provide valuable information and social opportunities that many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Tuesday, typically at 7:30 p.m. Eastern Daylight Time. All of the programs are free. The meeting announcements and whenever possible, the recordings will be posted on our site at edsawareness.com for future replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. The store is the only funding for this program and usually covers our monthly web fees. Please visit our store and check out the helpful products that we sell. Just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911. Always consult your doctor before making any changes to your treatment.
Our next webinar is on December 15th. Dr. Petra Klinga presents Tethered Cord Syndrome in EDS. And here are some of our upcoming speakers for 2016. Please see the webinars page on our website for the full schedule. For those attending live, there will be an opportunity for Q&A after the presentation. Add your questions at any time by clicking the Q&A icon at the top of your screen. After typing your question, click the orange button to submit. Our speaker tonight is Kelly Clancy. She will talk about manual therapy approaches for EDS. Kelly has been practicing occupational therapy for more than 29 years and is a structural medicine specialist, a board-certified structural integrator, and holds certifications in hand therapy and Bowen work. She's also a licensed massage therapist specializing in a new form of manual therapy called Tensegrity medicine. She obtained certification in holistic health counseling from the Institute for Integrative Nutrition and is on the clinical faculty at the University of Washington's Rehabilitation Department, where she lectures on topics of ergonomics, fascia, and hand therapy. Kelly is the owner of the Seattle Center for Structural Medicine in Washington, which is an integrative therapy clinic housing multidisciplinary practitioners. In addition to treating patients, the center houses a teaching studio from the same location, the Northwest School of Structural Therapy, which provides ongoing educational opportunities for manual and movement therapists. Kelly has published and lectured nationally and internationally on topics of fascia and its primary role in musculoskeletal dysfunctions. And she currently teaches classes on manual therapy strategies to affect overall alignment and function. And now it's my great pleasure to introduce Kelly. Welcome. We're looking forward to your presentation, and I'm going to go ahead and turn over the microphone to you. And you should see your slides loading now.
I want to thank John and Deanna for inviting me to speak with you all tonight on new and emerging manual therapy approaches. As Deanna said, I've been practicing for 29 years, and I've always had a special interest in working with individuals with chronic pain. And I started down this road of understanding postural alignment in fascia when I saw that many of the interventions that we were utilizing, such as surgical interventions and localized treatments, were not serving our chronic pain population. So I went on a search to find other answers and other ideas on how to help people who are suffering from chronic pain, and I want to share some of those ideas with you this evening. So what I'm practicing now is what I call Tensegrity medicine. Tensegrity medicine is a new paradigm in therapy. It's a whole body fascial approach. It's based on the concepts of biotensegrity, which I'll explain further. It's very different from traditional occupational or physical therapy, which is usually strengthening based. I'm not looking at specific isolated muscles, tendons, ligaments, or bones when I'm working with individuals. I'm instead working on the interconnectedness of all of the systems together. And so that includes the systems, the major systems in the body, such as the nervous system, the musculoskeletal system, the venous and arterial system, the lymphatic system, and the fascial system, and how all of these are working together to hopefully create homeostasis within the system. So this whole body approach utilizes body-centered therapies that incorporate whole body movement. So instead of looking at isolated joint range of motion or isolated movement of a particular muscle or muscle tendon unit, I'm looking at what I call long chains of movement, how the connections work through the system from the feet, through the hips, through the thorax, up into the shoulder and out into the hand and neck. I'm also interested in looking at the mind-body relationship and how stress plays a part in our musculoskeletal tension patterns. And with looking at the whole body and the whole musculoskeletal and fascial systems, we have to look at nutrition and hydration because they're the fuel for what's happening in our connective tissue. We're also looking at the ergonomics, the external environment, and how individuals are interacting with their environment and how their posture is interacting with the devices that they're using. So a lot of this approach is educational in nature as well as hands-on. So first I want to define fascia. It's something that is actually really changing in the area of medicine as far as our understanding of it. So it's a system that has typically been ignored. When I was in school, we were told to kind of cut through this very thin connective tissue layer when we were doing our anatomy dissections to get to the important things like the muscles and the organs and the other structures. But instead now what we're discovering is that this thin connective tissue layer that's encapsulating compartments of muscles and muscles themselves and nerves and veins and ligaments is actually a communication network, and its health is influencing the impact, it's impacting the health of everything that's within it. And so by focusing on fascia as the primary mode of intervention, you can affect all of the systems. So we do know now that the fascial network is a whole body proprioceptive network, meaning that there's information being relayed on where our body is in space and how we're able to utilize our extremities for functioning. And what I've discovered with working with a lot of folks with EDS is that this can be quite impaired, the proprioceptive system. So, people have often told me that they have felt like they're clumsy their whole life, that they've, bump into things very easily. They maybe were labeled as a kid with sensory integration dysfunction. And because of the nature of EDS, I believe that the fascial network is altered and therefore the proprioceptive network is altered. We're also seeing that the fascia is organized by stress, and so our bodies are pre-stressed, and the fascial system has a certain amount of tension that is always placed upon it to store energy and be ready to expel kinetic energy for movement. And so this pre-stressed network is also something that appears to be altered in EDS, where the tension patterns are not at the same levels as individuals without hypermobility syndromes. And one of the goals in treatment for me is to try to restore as much of the tensional integrity within the system to allow the normalization of proprioceptive feedback and the normalization of kinetic energy output. We're also discovering that fascia is a sense organ. So we used to think that it was mostly just a supporting scaffolding network, but now the newer studies are showing us that the fascia is communicating. It's like a nervous system that is communicating information through the whole network. And so some of the studies are showing that it's actually faster than the nervous system. So if this is the case, there's been a lot of correlation then to perhaps this is very similar to what we're seeing in Chinese medicine when we talk about the Meridian system and qi or prana or life force energy, that perhaps it's flowing through the fascial network. We're also discovering that it's adaptable to support its function, that it will lay down more connective tissue in certain areas when needed and will reabsorb when no longer needed. So that's a very positive thing for manual therapist specialists, because we can change the structure over time based on the input that we're giving it. We have discovered that 50% of the force transmission of a muscle contraction and elongation and with concentric and eccentric movement is actually happening through the fascial system itself, not the muscles as we once thought. And the health of the body is related to the fluidity and the degree of mobility within the fascial system. So it's very important then to have this system as healthy and as organized and as optimally functioning as possible. It's hydrophilic, meaning that it attracts water, and more than at least 50% of the volume and weight of our average physical structure consists of water. So when the fascial system is operating normally, it has what's called microvacuoles that will hold water in containment and allow the cells to be able to be bathed within this extracellular matrix and be able to function the way that they're supposed to be functioning. If the system starts to become dehydrated and the microvacuoles are no longer able to contain that water content, then we'll start to see some changes in density of the fascial system, and there'll start to be some deterioration in the ability to have sliding and gliding within the fascial network. So this is a photograph that was taken by Jean-Claude Gomberteau, who is a hand surgeon in France. He was studying the excursion rate of flexor tendons with his endoscopic microscope, and he came upon this universe of fascia within the system and started to film it. So this is just a still shot. You can find out more about his work by going to YouTube under Strolling Under the Skin, and you'll find small takeouts of his videos, and narrative about the fascial system. It's very, very interesting. So as I mentioned, within the fascial system is our musculoskeletal, our vascular, our nervous, and our lymphatic systems. And any adverse presentation of those isolated or combined systems would directly be influenced by the health and the positioning of the fascial connective tissue matrix. So what I have found in my own clinical practice is ways to identify restrictions within the system through objective testing and the ability to treat those areas of greatest restriction and free some of the fascial network to be able to allow these other structures to become more organized. This is a nice schematic of what the fascial network looks like. This is a representation of a tendon in the circle at the bottom of the screen. And then you can see how these connections are happening all throughout the system. And this is just showing the top portion of the connections of the fascial systems into the superficial fascial layer, and then at the roof of that is our skin layer. So when we have any kind of surgical intervention or any kind of trauma to a particular area, you will have trauma all the way through this fascial network, and you'll change the tension patterns through the system. So injury can also happen through things like inflammation within the system. It can happen with poor posture or any kind of trauma. And when that occurs, we'll start to lose flexibility and spontaneity of movement within the connective tissue matrix. This will subsequently cause biomechanically insufficient movement, and we'll start to then have a kind of a cascading effect where then we don't have the joints in the correct location and the right balance circumferentially around those joints, and then we'll start to have further changes in posture as the body learns how to compensate. So as I mentioned, we have this force transmission that's happening through the connective tissue system. We also have perforating vessels that are the peripheral nerve endings that are going through the superficial fascial layer, and they're often the same points that have been described as acupuncture points or trigger points within the system. And so often if these are tensioned or tractioned in any way, then they can contribute to chronic pain symptoms. So there's three main components to the fascial system. Primarily, it's made up of collagen, which is going to be providing strength and guarding against overextension. It's made up of fibroblasts, myofibroblasts, which are the contractile cells. It's also made up of elastin, which is going to absorb the tensile forces and provide flexibility within the system, and also ground substance, which is a gelatinous type substance that is made up of mucopolysaccharides, and this is part of the interstitial fluid that's bathing the cells within our structure. So it's kind of like the environment that our cells are living within. So if there's any disease or dysfunction within that environment, then the cells will be influenced. There's newer research coming out from the most recent Fascial Congress that was just held in October in Washington, D.C., and looking at the links of inflammatory disease processes with the health of fascia, and also looking at the role in oncology and cancer and fascia, and how we may be able to be looking at interventions of the fascial systems and how that can influence cancer treatments. So we also look at the role of fascia as a supportive role. It's facilitating metabolism in that it's allowing the lymphatic system to operate efficiently. It's helping protect structures and keep them in the compartments that they are supposed to be within so they can operate as normally as possible. It's also playing a role in the fluid flow throughout the system. It's separating structures. There's different septi that are created from the fascial system. It's going to be responding to load. So depending on how much tension is placed on it, the system will react accordingly. And there's certain parts of the fascial system within the body that have more collagen to create more stability. such as an IT band on the side of the leg, and other structures that have more mobility or elastin or ground substance to allow more sliding and gliding to occur. So that will facilitate the movement between the adjacent structures, and also when there's any kind of dysfunction, it will hinder the movement between adjacent structures. So often what I see in my clinical practice with individuals who have restrictions in their connective tissue system is that there'll be adherence between the compartments. So an individual will go to use their quadriceps to be able to walk or to be able to move, and they'll have adherence of the muscles on the inside of the leg or a pulling that is twisting the leg and causing more of perhaps even a hamstring pull. So one of the focuses that we do at our clinic is we test the connective tissue system and release the tightest threads within the system and help restore three-dimensional balance through the limb, which can increase efficiency. It can help improve strength and coordination and allow for full range of motion of the joint. And the very, very interesting thing that I have found is that surprisingly, my EDS population are the tightest in their fascial network. And I was quite surprised by that. I thought it would be the absolute opposite. But what I'm seeing is that there's a lot of hyperrotations that are occurring within the fascial network, and it's causing and contributing to the joint hypermobility, but also contributing to the pain and the misalignment issues that are occurring with this condition. So we've talked about its importance in cellular health as well. So one of the reasons why I think we haven't really talked much about this system in the past is that the way our medical system is set up, we're very reductionistic in our viewpoints and reductionistic in our specializations. So for many years, I specialized in the upper extremity, and I just treated people who had shoulder, elbow, wrist, and hand problems. And I became the expert in that field, one of the experts in the field. But what I recognized is that if you don't have the correct postural positioning of the rib cage and the pelvis is not in the correct place and the feet are not in the right alignment, that the whole upper body will never be in the right place and that you will always have dysfunction as far as alignment. So that's when I went back and got further training to really understand the postural components to disorders and disease processes that are happening in the body, and have taken a much more global viewpoint of how to interact with disorders or dysfunctions that are happening within the system. As I mentioned, we also were taught in anatomy dissections to really not look at the negative spaces between denser structures, but to look at more of the dense matter. But what we found is that within this fascial network, there are these, it's holding together these negative spaces, and that's actually equally important or perhaps more important than the denser structures that we dissect down into. It's also very interesting. I've done a number of fresh tissue dissections that don't use any kind of chemicals, so you can really see what this fascial network looks like. Because as I mentioned, it's hydrophilic, it attracts water, and any type of chemical put in the deceased body will actually take the water out and change the fascial network. So it's very helpful to look at the human body without any chemicals being placed in it. And when you do that, you actually could really see this connective tissue matrix through the system. And numerous anatomists have told me that once you start to cut through this kind of negative space or this fuzzy appearance of connective tissue, that you'll alter the tension patterns through the whole system. So I often describe it kind of like if you were to take the skin off of a chicken that you're getting ready to eat, and you see that thin connective tissue layer underneath it. That's one layer of our fascial system. So another way I describe it is it's kind of like a three-dimensional onesie, if you have ever worn little onesies or put them on your children, but it goes through the whole system. So one tug on the fascial web will be communicated across the entire fascial web, like a tight thread on a sweater or a twist in a shirt or pantyhose. This is an actual dissection of one of the arm lines in the body. And in the upper left-hand corner is the trapezius muscle that goes onto the back of the neck and the shoulder. And you can see the continuity going down into the triangular piece just below it, which is the deltoid muscle that encapsulates the shoulder. On the lateral side of the upper arm. And then as we see those pieces come off the center point at the distal portion, that's right around the elbow. And all of those are the forearm extensors, and they feed down into the digits. So you can see how when we really look at it as a continuity, that we see this is all one fascial line and it's all one piece. A gentleman by the name of Tom Myers wrote a book called Anatomy Trains. He is a structural integrator in Maine, and he was able to prove and dissect out these fascial lines through the whole system. And where he found is that there's myofascial continuities that go from the bottom of the feet to the top of the head, down the back, and then there's also matching ones on the front that go from the front of the feet all the way through the front of the head. There's also lines that coordinate and correspond laterally. There are spiral lines that go through the system, and there are lines that go, 4 lines that go down to each arm. So when we look at all of this, it really comes down back to posture and why we're looking at posture in a therapeutic setting. There's many definitions of posture, one of them being that it's a position of the body with respect to the surrounding space, and it's determined and maintained by coordination of various muscles, or we could say myofascial lines, that move the limbs, by proprioception, understanding where our body is in space, and by a sense of balance that our system can create three-dimensionally. It's also an attitude of the body. So it's something it is usually considered to be the natural and comfortable bearing of the body, but you can imagine how you can read emotions often in people's postural positioning, and it's a little bit of like a chicken and the egg. It's hard to know which came first, but you can imagine that if you've had a really hard day and you've been having a really difficult time, how it'd be very hard to maintain an upright posture. You would naturally want to bring your head forward and drop your sternum, internally rotate your shoulders, and kind of take on more of a defeatist kind of posture. So when I'm working with individuals, it's always really important to be addressing not only the physical structure and how it's organized, but also what happens when we are altering the physical structure and what happens to our emotions that go along with that. So I do a lot of dialoguing with my client around cognitive belief patterns, emotions, lifestyle management skills, and how we could coordinate not only postural changes in the body, but tie the emotions along with that. So this is all very important because when the integrity of the structure of postural muscles are compromised, the skeletal system is affected, the whole skeletal system. And nobody knows that probably more than somebody suffering from EDS, right? So these misalignments are going to lead to abnormal wear and tear on the joints. They're going to cause musculoskeletal breakdown or injury or pain. And when this occurs, you can also have the internal systems be affected. The body will naturally try to compensate for these dysfunctional patterns to try to allow it to be as adaptable and as functional as possible. But often it's these compensatory strategies that can lead to further disorganization and dysfunction because the correct joint positioning is not occurring and the muscles are no longer in the right place and able to fire correctly. When these things happen, the nervous system can become tractioned. It can also become compressed or both. And when that happens, we know that pain can become significantly increased and can further cause deterioration in function. So when fascia is damaged or altered, like I said, we can end up having these injuries through inflammation in the system or poor posture or trauma. But we will definitely start to lose flexibility and spontaneity of movement. We'll become more biomechanically insufficient. And as these fascial restrictions develop, we'll start to have changes in the length of our connective tissue and the overall mobility of the sliding and gliding. What often happens when there's restrictions in the system, the whole system will start to shorten, and it will shorten into spirals. So an analogy that I see is like if you were to take a dish rag and you were to twist it in opposite directions on both sides. When you do that excessively, what will happen is the dish rag will shorten. And that's what I see often with EDS clients is there's significant restrictions, spiral restrictions in the system, and then the joints end up getting too close together, and then their only way that the mobility is happening is through moving the joints in a hypermobile fashion. So, of course, when this happens, we have dislocations, we have bone-on-bone kinds of issues, we start to have breakdown in the connective tissue system itself. So again, the goal of treatment is to be looking at the whole system as a whole unit and making sure that the treatment is involving three-dimensionally balancing not only parts of the system, but their relationship to each other. So we used to think that to change connective tissue, we needed to apply about 5 grams of force to alter the collagen formation. So when I was in structural medicine school, we ended up using a lot of force with our manual therapy. And for many individuals, the treatment was kind of painful because it was like a very firm massage. And now what we're starting to understand that the connective tissue system is holding the nerve endings within the peripheral tissue, and that those nerve endings in the peripheral tissue are acting like little antennas, internal antennas, and they're responding in different ways to different kinds of feedback. So in some of these nerve receptors will be responding to light touch. Some of them will be responding to deeper pressure. Some will respond to vibration. Some will respond to a shear. And all of these things will cause the nervous system to have a reaction that, when applied in the right way, can cause a resetting of the tissue tension patterns within the system. So I use many different kinds of manual therapy based on the assessment to determine what would be the best mode of intervention for that individual to get their nervous system to reset the tissue tension patterns. So I'm always looking at the fascial system and the nervous system really working in unison together. And when the nervous system feels like it's under threat, it will have a stress response that causes either a fight, flight, or freeze response. And I'm sure many of you have experienced this, maybe in a therapy setting or in a medical setting, that it's no longer, you have a difficult time being able to access a relaxation response or letting your tissue reset itself if you're in a fight, flight, or freeze response. So with manual therapy interventions, when there's very tight restrictions, it's really important to be able to calm the nervous system and to find modes of intervention that the nervous system is going to be able to accept in a non-threatening way. So I really look at these stretch receptors or these nerve receptors within the fascial network as kind of our sixth sense. They let us know where our body is in space. They let us know when our body stops and another body starts. It helps us understand and feel sensations within our system, and also to be able to respond to more of our instinctual parts of ourselves that can make decisions and do what's best for us. So this is a nice schematic of these mechanoreceptors that are found on the superficial layer of the skin. So if you were to imagine that the skin layer is at the top of the screen, and each of these bulbs represents one of the nerve endings, and they each have kind of a different antenna frequency based on what kind of input is being given to them. So like I said, some will respond to light touch, some will respond to vibration, some will respond to a shearing, some will respond to pain. And each of these will then send information back to the central nervous system and tell the central nervous system how to respond in relation to tissue tension patterns. This is another nice schematic of looking at the skin at the top of the screen and then all these little peripheral nerve bundles that occur. So when I really started to understand these concepts, I recognized that you really don't need to push, or you don't really want to push very hard on the myofascial system, because you'll give too much input or not the right input to these peripheral nerves. So many of you might have heard of Buckminster Fuller. He's one of our great thinkers of our time. He coined the term tensegrity. Tensegrity is looking at combining the equal forces of compression and distraction, and how when we put these equal forces of tension and distraction together in a three-dimensional structure, you actually create balance within the structure. You create stability, but you also create flexibility. It's a freestanding structure that can organize itself without gravity as its influence. And so we can start to look at the body as a tensegrity structure, that we no longer need to think of it as more of a biomechanistic approach, which is really how we're taught in medicine how to look at the body, that we're no longer columns like towers or blocks, but instead that we're nonlinear biostructures, and we're surrounding a vertical central axis, which is our spine and is our internal organs, but that all of this biostructure is three-dimensionally balanced. This tensegrity structure then has the ability to resist deformation. It's much stronger and can't be toppled over easily, usually. And that it's kind of like we have, like I mentioned, we have these pre-tensioned networks within our system via the connective tissue that stores energy and allows us to have elongation as well as the ability to absorb compression forces. So when all of this is integrated together, it actually will help hold our structure open. It's like our bones are floating in a connective tissue matrix, and that when the structure is organized in this way, we'll have a lot of buoyancy and elasticity. So I was at the International Fascial Congress, and I was walking around Washington, D.C. and looking at these structures and thinking we're not really like the Washington Monument like we used to think we are, but instead we're like Kenneth Nelson's Needle Tower at the Smithsonian, and that each of those rods is our bones floating in connective tissue, and those cables are our fascia holding us all together. So a physician by the name of Stephen Levin really started to talk about these concepts of biotensegrity about 40 years ago, and he's gained a lot of popularity recently when individuals start to look at the body this way. And if you're interested in learning more about his concepts, you can go to biotensegrity.com. So as I mentioned, he is describing he was an orthopedic surgeon who was doing surgeries on spines. And when he started to study Buckminster Fuller and his concepts, he started to look at the spine in a very different way and saw that each of the vertebrae was a continuous compression member, and it was holding the connective tissue around it. The muscles and the fascia were ensuring that there was correct spacing between the vertebra, and so there would be correct mobility of the discs and correct mobility of the nerves that were coming down through the columns. This is a representation of a tensegrity structure that was created by Kenneth Nelson, and you can get the idea that if you were to pull one of these cables out of position, that all of this would fall. But from an EDS perspective, how I see this is that there's been an alteration in the tension and compression patterns within the connective tissue matrix that is making some of these struts be a little bit more elongated and some of them to be a little bit more compressed and close together. So that can lead to restrictions in range of motion or excessive movement in range of motion and alter the positioning of the rest of the systems within the body. We see these concepts in nature, and like I said, here's another example of Kenneth Nelson's needle tower of the equal balance between compression and tension. So there's three main laws about these ideas, that the tensegrity patterns are always continuously connected, and they're supporting discontinuous compression struts. Those struts never touch each other. It's also self-supporting and pre-stressed, meaning that it's independent of gravity. You could turn this on any side and it would still retain its form. So it's self-contained. It's dynamically linked that any change in the system is reflected through the whole structure. So when I started to look at the body this way, I started to really recognize that our systems, each of our joints is a biotensegrity structure, and that our bones are floating in this connective tissue, and that any alteration in part of the system will be affecting other parts. So that became very important when I'm looking at postural alignment, and I have an individual coming in who's having neck pain or back pain, hip pain, ankle pain, that instead of looking at the very specific part of the body that is presenting with pain, I now need to look at the whole system and how is it relating to itself. Donald Ingbar is another physician who started to look at these concepts of Buckminster-Fuller, and he applied it to cell biology. And he's been able to demonstrate that cells within our system also act as independent pre-stressed tensegrity structures, which is really, really fascinating. So we no longer are looking at the biomechanistic viewpoint, in my clinic at least, and that by addressing some of these compression and tension elements that we can help restore more balance and therefore reduce pain within the system. So this is a nice schematic of looking at the muscle tendon units and how having the right tension patterns can create the right positioning for bones. And this is from Stephen Levin's work. We look at that the shoulder is its own tensegrity model, the elbow is the same, the wrist and the hand, and that if one of those is off, the whole thing will be off. And you can extrapolate that into the whole system, the whole body. So as I've mentioned, I've talked a little bit about proprioception and our ability to know where our body is in space. This is happening through our connective tissue system, and it's informing the brain of our movement patterns and our movement habits. So we used to think that our proprioception was actually happening at the joints themselves. We have a lot of mechanoreceptors at the joint, but now we are understanding that it's actually happening through the connective tissue on that superficial layer of skin. So this concept of having tissues that's locked long or locked short really is important when we're looking at conditions like EDS. And as I mentioned, we start to see hypermobilities that are occurring in the joints because of the significant myofascial restrictions or the twisting that occurs within the connective tissue itself. So in my medical literature, I was always told that the best way to work with Ehlers-Danlos was to work on isolated strengthening of particular joints. And the feedback that I've gotten from many of my clients is I just get more and more sore when that happens. And I agree that if the system isn't correctly aligned, if the joint positioning, the arthrokinematics is off due to fascial twisting within the system, then isolated strengthening around that joint will actually probably cause more compensations and more dysfunction in the system. Where strengthening can come in is when you have changed this tensional balance within the system and you've restored as much three-dimensional alignment as possible, then it's really important to try to bring it into functional movement that incorporates a lot of stabilization strengthening, including isometric, eccentric, and concentric exercises. So one of the things that they're discovering in the fascial research is that a lot of the load bearing and the elasticity we used to think was happening within the muscles themselves, and now we're understanding that it's actually happening within the fascia. So some of the newer, trendier exercises that we're seeing are using things like foam rollers and balls to be able to self-mobilize connective tissue, and those can be helpful in only when they are applied in the right way and in the right direction and with the right amount of force. So I'll sometimes use these tools in between sessions for my clients, but I'll only use them when I can demonstrate them in a way that's going to be most efficient and to help effectively move the connective tissue in the right direction. I'm not a fan of hard foam rolls. They seem to cause more pain, and the nervous system, again, will go into a protective mode when we're rolling on something that's quite hard and quite fast. So I like the softer foam rollers, the softer balls. And like I said, then once the structure is organized, then isometric contractions can be really good. So I also am a big fan of what I call long chain exercises. So things like Qigong, Tai Chi, things that are slow and purposeful and mindfully done, where the attention is ever present and only to the end ranges that is available to the individual that's non-compensated in the range of motion. So the studies are showing that with the contraction of the fascial system and the musculoskeletal system, the muscles themselves, that it's acting as kind of like a sponge. You're able to hydrate and rehydrate tissue by participating in movement. So I'm a huge proponent of movement. It just has to be the right kind of movement. The other thing that I'm a huge fan of is actually breathing exercises. So respiration is going to help with overall functioning of the system and oxygenation, but it's also going to help with the nervous system and help restore more of the parasympathetic mode. It's also going to assist in core mobilization because the respiratory diaphragm is directly connected to the psoas muscle and up in through the mediastinum that's on the other side of the chest wall. And all of the mobilization that can occur there can really have healthy benefits for us. So I do get a lot of people who ask me, well, I just think I'm getting old. My doctor says I'm just getting old and these things should be happening to me. And I don't agree that the way that we have classified aging is really what needs to happen. I think we have a lot of control over how our system ages, and we can influence it with the correct kinds of movement and the correct kind of nutrition and hydration. So the paradigm that I've developed is called Tensegrity medicine, and as I have been talking about, it's a fascial system intervention that is based on biotensegrity and three-dimensionally balancing the body. I use treatment techniques that help reset the tissue tension patterns. I view disease and disability as a means for evolutionary growth. It's not something to get rid of and to have a war against, but instead to use the symptoms that are occurring in the body as a way to lead us into being able to evolve and to find our greatest strengths through what we have maybe perceived as our greatest suffering or weaknesses. And that manual therapists can act as coaches and support services, not to fix the individual that's coming for treatment, but to help facilitate how the client can take back control and give them some resources on how to manage their symptoms. So we really are understanding the nervous system and its role in tension patterns through the system and health and healing. So a lot of as I mentioned, a lot of my treatments involve dialoguing and helping people find resources to help calm their nervous systems. There's two types of roles that your autonomic nervous system can take on, and they're both very important in different situations. We can have our fight, flight, or freeze response, and we can also have our rest and digest. So when we are needing to heal and we're needing to recover from an injury or a trauma, we need to be able to allow our body to get into its parasympathetic mode. And often that can be quite difficult and challenging when the system is feeling like it's threatened. So that's one of the things I found in my 29 years of clinical experience is that it's really important to try to create an environment, a therapy environment where people feel like they can come to and experience restoration versus feeling stressed during their therapy sessions. There's also a really important role that nutrition plays in our fascial and our connective tissue musculoskeletal health, including the avoidance of inflammatory foods. So this is one of my first home exercises for my clients, is to start looking at their sugar intake specifically and see if they can reduce that. Refined sugar is naturally an inflammer of the system. And also looking at intake of processed foods and any other potential food sensitivities that might be causing an inflammatory response. Also looking at hydration and making sure that we're getting enough water to be able to help restore some of this correct gliding and sliding within the fascial network. I'm a big proponent of plant-based, nutrient-dense whole foods, and like I talked about, really being more mindful with not only our movement practices, but also our eating practices. So there's lots of forces that are shaping us. There's our genetics, as many of you are dealing with, our movement patterns, how we're holding our body in space, our physical environment and how we have set ourselves up to interact with it, the biomechanics of tension and compression, as well as gravity. So things in nature learn how to adapt based on their environmental settings. We do the same. We learn how to adapt to be able to function. So often what I have found in the clinical setting is that the site of pain is often not where the problem is in the system. And so we may have to balance the lines of pull. I may have to work on somebody's leg and derotate their leg to get their pelvis in the right position to help their shoulder be sitting on the thorax correctly. And so it's a little unconventional, but it's something that I've consistently seen can resolve a lot of chronic pain symptoms. I do this through myofascial testing, which is a form of objective testing of the connective tissue system. It lets me understand where the true holding patterns are within the system and to find out where the twists and the tugging may be occurring, and then know where to have my interventions in manual therapy. So I applied this objective testing prior to treatment, and then I apply it after to see if we actually got what we were expecting. So through Tensegrity medicine, I'm able to assess each individual with an individualized manual therapy approach and using objective measures, and then be able to educate the client on how they can take some of these new patterns back into their function and their home life. So as I've mentioned, we do this through whole body movement, stress management, ergonomics, nutrition, all of those things. So some of the manual therapy techniques that I've been using have been really exciting and have been evolving over time. One of them is called structural integration. And structural integration is something that was developed by Ida Rolf. She was a biochemist and started to look at the structure and the organization of structure and began to study fascia and found that if we can reorganize the connective tissue and create more of this alignment through the whole system, that people could evolve not only in their physical structure, but also evolve emotionally and from a more humanistic point of view. So that's one way that I'm intervening with the fascial system. I think of myself as kind of a detective. I'm trying to find out where the criminals are in the system, and the victims are usually where the pain is being felt. And through these postural imbalances, I can find which structures are locked long and which structures are locked short. So as I mentioned, by using this integrative process, then we are able to give people their own tools and resources to be able to make changes. So I've talked about structural integration. I'm going to also talk about ligament stimulation. This is a new technique that we've developed where we are using ligaments and gently tractioning ligaments, and are finding that when we traction the ligaments that are corresponding with a particular area of the body and shortening the muscle that is having a lot of hypertonicity while we're tractioning, we can ask for the body to create opposite contraction. So if I was trying to get your bicep to relax, I could find the corresponding ligament and get your tricep to isometrically move. And by doing this, what's called reciprocal inhibition, we can reset abnormal tissue tension patterns within the system. So I've developed protocols around this to change and balance the connective tissue system. It's a very gentle technique that is using neuromuscular reeducation and isolated isometric movement. So it's very safe for folks who have a lot of hypermobility or pain at end ranges. And often individuals feel quite different after receiving the treatment when they stand up and start to move. So this is an example of a position I'd put somebody in and stimulating their medial collateral ligament and lateral collateral ligament while I'm trying to get their hip flexors to let go. I also utilize the craniosacral system through Craniosacral Therapy, which has been developed by osteopaths throughout the years. Andrew Still is the founder of osteopathy. And he talked about how the bones are the starting point, the cranial bones are the starting point to be able to change the system. So not only the cranial bones, but the whole dural tube around the spinal column. So the philosophy of osteopathy looks at that, again, like I talk about with Tensegrity medicine, that we need to look at it as a whole biologic unit, and that the body has its own self-healing and self-regulatory mechanisms, and our structure and our function are interrelated. So we restore the correct positioning, and we can, the body can then go ahead and heal itself. So this philosophy has been practiced with many DOs throughout the world with really exciting results, and you'll find usually it's doctors of osteopathy and naturopaths and physical and occupational therapists who are practicing it. One of the other really exciting forms of manual therapy that I have come across in the last 10 years is Bowen therapy or Bowen work. It was developed by Tom Bowen in Geelong, Australia, and he was stimulating the nerve endings in the superficial fascial layer by applying a very light touch cross-fiber soft tissue mobilization over certain points in the system. And he found that by stimulating the mechanoreceptors in this way, followed by a brief waiting period of usually around 2 minutes in between the moves, that he could get the connective tissue system globally to reset. So this is probably one of the most exciting manual therapy techniques that I've come across in my career, and I now teach this nationally and internationally and have had just astounding results in relation to chronic pain. So if you want to try Bowen therapy, you can go to, if you're in the United States, you can go to the American Bowen Academy website. Just Google American Bowen Academy, and you can put in your zip code and find if there's any practitioners in your area. There's a picture of Tom Bowen. He was actually a layperson and really self-studied and self-developed this technique. So it's interesting. It's very multidisciplinary now. There's people from all different practices and people around the world that are working with it. So it's been described as a neuromuscular reeducation technique, but the whole theory is that really that the body knows how to heal itself if it's given the right information. and that we can do it in a very gentle way. It's a very relaxing technique, and it can be done closed or not closed. It can be done in any position. So I've worked with people in sitting, sideline, whatever, wheelchair bound, whatever feels most comfortable that will allow the individual to really relax. It's also safe for children, newborn babies, the elderly. I've worked on children as young as 8 weeks, and I've worked on people in their late 80s. So usually people can tell, I would say within the first 4 to 6 sessions, if this is going to be something that's going to be helpful for them. Some people will have very strong responses either way, that they would have a strong response that they'll feel, very strong, maybe a lot of discomfort after the session. Other people will feel like they're pain-free after the session. It seems to really vary, and it depends on how much the practitioner is doing. So I usually recommend that if you've never had Bowen work before and you have a lot going on, that you make sure and have the practitioner start with you pretty slowly, because sometimes it's kind of like a medicine. You don't want to do too much on an individual who's maybe a little bit more compromised. So there's been a lot of studies that are going on around this technique. In different countries, it's called different things. So I just came back from Australia, where I was teaching some forms of Bowen work around postural analysis, and that's where it really started. But you'll also see it in Europe called the Bowen technique. You'll hear other things like neuromuscular structural integration is another offshoot of Bowen work. But it's been in the United States since the early 90s. One of the primary things that I think it does is it really helps the body get back into balance again. So I have lots of folks who I've been using, a lot of EDS folks I've been using Bowen on, and they tell me that they feel like they've just kind of been reset, that their system feels like out, that their pain is down, and that a lot of their system feels like it can just operate a little bit more efficiently. So as I mentioned, the technique itself is really, really light, but the move is where we just take a little skin slack over the skin. We apply very light pressure and hold that pressure for 2 to 3 seconds, and then we roll over the muscle or the tendon or wherever the location is that we're applying the Bowen move. And then we wait for a couple minutes after we've done a series of moves and let the nervous system respond. So we do this at the low back, the upper back, the neck. We have different sequences based on why an individual is coming to see us. And based on their symptoms, we may choose procedures that would involve the jaw, would involve the ankles, involve the low back. It really depends. I think we're really stimulating the autonomic nervous system with this technique, and that it's helping, as I mentioned, reset this homeostatic reorganization of the autonomic nervous system, which basically means that it's a very relaxing technique. So when we talked about the autonomic nervous system, if you're able to get the body back into a state of rest and digest, then it can start to repair and regenerate. I also think it's changing the fascial system and allowing the alignment to be restored from a tensegrity viewpoint. And when people have any of these adhesions or changes in length occur, then the joint mobility will naturally improve. So there's, like I said, lots of studies going on about, what's happening. Are we stimulating the spinal arc reflex, or, are we stimulating these mechanoreceptors? And for this presentation's purposes, maybe that's not as important, other than that there are techniques out there that can be really gentle on the system. So I'm going to kind of move quickly through this last portion because we have covered this in some detail, but I have had many patients tell me that they feel like their digestion's better, that they are able to take a deeper breath, that they're sleeping better, that even some of their mood has changed with this technique. And that's all really exciting, as well as stimulating the nerve endings in the system that are changing pain patterns throughout the structure. So it's very safe. There's no contraindications, and there's just a couple moves that we wouldn't do with pregnancy, but otherwise there are no contraindications. So from a healing perspective and being an occupational therapist, I'm always interested in finding low-cost, safe, and effective means to help relieve pain without harmful side effects and to help give people the locus of control back to help them help themselves feel more healthy. So I get very excited about a lot of these practices that are incorporating more wellness-oriented kinds of approaches, and I see that this approach of Tensegrity medicine is able to do that, incorporating a lot of these manual therapy techniques. So thank you very much for your attention, and I'm happy to take some questions.
Thank you, Kelly. This is really exciting. We're going to go over to the questions from the live attendees. You can click on the Q&A box to find out what questions are in the queue for you.
Okay, so should I just go ahead and read these out loud?
Yes, please.
Okay, so do you know anything about new bracing systems? I've heard from my manual therapist a recommendation for DMO bracing, which is a thin type of clothing that's modified specifically to where the user needs more or less support to accomplish some movement, and there are others. How do we go about finding such products? Well, Susan, I tend to, I used to do a lot of splinting. I do a lot of kinesiotaping now, and I do that based on where I'm feeling the tension patterns within that individual system. The kinesiotape is, or rock tape, there's lots of different brands, allow the practitioner to be able to put the tape on, and the tape will stay anywhere from 3 to 5 days, and it's specific for that individual. Sometimes when I see some of the advertising for the thin type of clothing, it's hard because I think each of us has our own patterns and each of us has our own rotations. And so to put on a standardized set of clothing that may or may not fit your particular pattern, it might set you up for being helpful in some areas and maybe not in others. So I haven't been drawn to that area of treatment, so I probably wouldn't be the expert in telling you where to find it. So the next question is, how is this expressed in someone Medicare age and especially after joint replacement? Well, it's a very interesting thing, joint replacement, Helen, because often a joint will start to wear down, have wear and tear on it because there's been misalignments above and below the joint in the connective tissue. And so when we have this, say, a twist in the upper leg and a twist in the lower leg that's going the other way, you'll start to wear out a knee. And so if you get your knee replaced, the twist hasn't been taken out of the connective tissue system. So often what happens is that force can be placed somewhere else in the system. It can be put maybe up into the SI joint or down into the ankle. So whenever I'm working with somebody who's had a joint replacement, I make sure that I've tested the connective tissue and helped try to restore the three-dimensional balance of the connective tissue to help create better alignment of the joints above and below the joint that's been replaced, and to help ensure that there's more success with joint replacement. So can we find people trained in biotensegrity on the East Coast? Well, it's something that is really emerging now. I run a Tensegrity medicine mentorship programs out here on the West Coast. I have a lot of interest in starting them on the East Coast and abroad. So hopefully in the next couple of years, we'll really start to see more people practicing this way. I'd say in the meanwhile, you could be looking at individuals who are practicing whole body manual therapies. And so there's lots of different kinds of whole body manual therapies. Some of them are more aggressive than others. So you have to figure out what's going to work for your system. But Rolfing structural integration is from Ida Rolf's theories. That tends to be a little bit more aggressive. Craniosacral therapy, ligament stimulation, and Bowen work are much more subtle and soft on the system. I'd also encourage you to try to find movement specialists that specialize in things like gyrotonics or Tai Chi or Qigong that can help reset movement patterns. Feldenkrais practitioners, Alexander practitioners are also whole body movement therapists. Question is trigger point dry needling safe and effective for EDS patients. I have many physicians who refer to me who do dry needling, and I think it can be complementary to other manual therapies that are going to help reset tissue tension patterns. Whoever's doing the trigger point or dry needling needs to be able to look very three-dimensionally at the individual and to ensure that whatever they're resetting as far as tissue tension is facilitating a three-dimensional change through the rest of the body, and it's not borrowing tissue from one place to restore it to another. So the theory is really good. It's really just more about the application and knowing how to balance the body. How valuable is hot tub therapy in resetting the fascial network? That's a good question. Any type of thermal input to the fascial system will help lengthen it. So we have different receptors in our fascial system. Some receptors, pain receptors, will respond better to cold, and some will respond better to heat. But we do know that any kind of hot packs, hot tub kinds of treatments, sauna treatments, will help elongate fascial system, at least temporarily. So it can be a really nice way of treating individuals who are having a lot of tension in their system and are having a hard time resetting it. But you have to be a little bit cautious because sometimes there's a bit of a rebound effect with heat, in that you can also create inflammation. And so it really depends on how long you're applying it for, what body part. I'm kind of a fan of combining hot and cold kinds of therapies to help increase blood flow and to reset tension patterns. So can you see myofascial trigger points on thermography? You know, I don't think so. I think you can see tension patterns in thermography. I'm not exactly sure though, Steve. What we're seeing is that we're seeing a lot of ultrasound is not therapeutic ultrasound, but diagnostic ultrasound is being used now to study the fascial system. Can you apply tensegrity in the pool or aquatherapy? Yes, most definitely. I think it's a matter, again, of who's working with you, if they're able to identify the restrictions in the fascial patterns and be able to have you move in a way that's going to help you unspiral out of those movement patterns. But water can be a great medium for therapy. The tendons in my arms can be seen after a shower. I use lukewarm water. What fascial changes may be occurring within this? Well, you're always going to have a change in the blood flow after any kind of thermal input. And so it might be a lot easier for you to see changes following a hot shower or cold shower just with the thermal changes. But that's something that will become more regulated as the body restores its natural tissue temperature. So Emily goes on to say, there have been times in my life when my upper body's in pain. It gets treated by OT or PT, and then I get pain and issues in my upper body. It's like a dance between the pelvic girdle, the shoulder girdle, neck. Very frustrating. The worst was both the shoulder girdle and the pelvic girdle, both on the same side of my body. It felt like a whole body migraine with intense pressure. Can you comment? I very much kept seeing this pattern over and over again in my patients, where I would treat one part of their body and then they'd come back and say, well, now I feel it in the area that you didn't work. And that's why I say that what will happen is the body will borrow tissue from one area, and if there's enough tension in the system, it'll take it from somewhere else. So I have a good example. I was seeing a patient last year who had a frozen shoulder, and she had seen everybody. She had gone to massage, acupuncture, many different things. And when I assessed her, I found out that her opposite hip was the most restricted thing in her body. So I explained to her this whole tensegrity system and the whole model, and I told her that I'm going to need to work on her opposite hip to get her shoulder to free. And she reluctantly agreed. And when I did that, her frozen shoulder resolved, because it's kind of like I was talking about with that tight thread in the system. It was tethering down her shoulder, and it made it unable for her to get the full length through the frozen shoulder until I could give the system more give. So when you're experiencing all right-sided pain, or you're experiencing kind of a shoulder pain and then a hip pain, and it's kind of a traveling pain, I believe that the fascial network is vying to try to create more balance through its whole three-dimensional system. Are there other practitioners or clinics doing this work in the Boston area? Michelle, I'm not sure. I would, again, go to the American Bowen Academy and see if anybody's practicing that particular technique. Like I mentioned, I'm hoping to do some training on the East Coast with practitioners, but I'm not familiar with anybody who's practicing this particular mode of therapy right now. The next question from Catherine is, the geneticist who diagnosed me insists that I practice Tai Chi. However, the diagonal movements are really aggravating my body, especially in my hips, my knees, and my ankles. I would say it might be helpful for you to practice Tai Chi in conjunction with one of these gentle movement therapies, one of these gentle manual therapies. I usually don't have people start any kind of long chain exercises until we've had at least 3 to 4 manual therapy sessions under our belt to try to give more give in the system. And then I recommend that you, if you have the ability, to try to practice it with somebody who's skilled in EDS and that can supervise you carefully to ensure that you're not going into any compensatory movements while you practice it, if at all possible. But I think that your geneticist is really on the right track when they're really wanting you to do more of these diagonal patterns and these more connecting the dot kinds of movements through the whole body versus an isolated strengthening exercise. I have a 7-year-old that is getting followed for scoliosis. Is it common with EDS, and what can I do to help prevent scoliosis from getting worse? I don't know about its commonality with EDS, but I do know that acquired scoliosis is an issue in the connective tissue matrix. As I talked about, the bones are just floating in this connective tissue, so scoliosis can be successfully treated with interventions that involve changing the connective tissue system and then teaching these long chains of movement. So I would try to get her involved with a practitioner who is familiar with some of these concepts and can apply them into her individual care. Is there anything specifically important for patients to mention when working with providers who are not familiar with EDS? Yeah, you know, my patients with EDS have been such great advocates for themselves and have taught me so much about how I know how to treat what I do with my patients when I'm working with them. I think the most important thing that I've seen is that you need to make sure your provider's looking at the big picture and that they're not treating you just where it hurts, but they're treating you in relationships. So if you're going to see somebody for a hip problem or a pelvic problem or a low back problem, they're also coordinating your care and doing techniques that are involving the positioning of your feet and the positioning of your shoulders and how you're moving all of those parts together, not in an isolated way. I have found consistently that isolated treatment is contraindicated for EDS. That's just my opinion. How long is a good course of manual therapy, for instance, for neck pain? 6 months of twice a week? Well, you know, Cheryl, it's interesting. I find with EDS patients, it's almost like there can be chronic re-injuring that's occurring. So what I'm looking for is can we justify care where there are goals that are being met and there are short-term goals and long-term goals that we can continue to work towards. So I have some patients that I see short-term for just, 6 sessions or so, 8 sessions, and they go on with the home program. I have other clients I've been seeing for a couple of years on and off, and it's just a matter of what they're trying to achieve in their life at that time, how much they're doing, how much they're able to manage their symptoms and stay within an optimal range of motion. So I don't know the particulars of your situation, but I would say if you feel like you're making progress and that you are seeing improvements, then it's probably important to continue. But if you're not, then you might want to be looking at other interventions. All right, so thank you so much for your eye-opening information. It makes so much sense. I had a tethered cord release on October 2012 with an additional L5 nerve impingement. My loss of glute strength has been compensated, but my posture is twisted and movement ataxic. I've been prescribed PT for my back. For those of us who are twisted and seek PT, what should we ask for from our therapists? By the way, I've enjoyed amazing benefits from Chi and recommend it highly for EDS patients. This is from Anne-Marie. Again, I would recommend that the physical therapist that's seeing you for your back, they make sure that they're globally working with you three-dimensionally and they're giving you activities that can help facilitate movement and or stability through the neck, the shoulders, the thorax, the pelvis, the legs, and that whenever you're working with an individual that they're really seeing the whole picture of you. And as I talked about in my talk, not only the physical part of you, but the emotional and the lifestyle that you're living in. Okay, how is Bowen therapy different from myofascial release? Well, Bowen therapy can be classified as a form of myofascial release. We're actually releasing tissue tension within the myofascial system. But the name myofascial release tends to be typically utilized with more aggressive forms of manual therapy, more grams of force being placed on the connective tissue, usually broader strokes that are being applied. Bowen therapy, like I said, is a very isolated technique, and it's very soft in its touch, and it almost feels like this can't really be doing anything. It's so gentle, but the effects can be really profound. So with the folks who I see with EDS, I often will try different types of myofascial release and Bowen therapy and find out what their system seems to be responding to better. And so I just have a different bag of tricks, a big bag of tricks of trying different forms of manual therapy to see what's going to be the best for that individual. Like I said, for Cynthia, for finding a Bowen practitioner in the Boston area, go ahead and look on the American Bowen Academy website and see if you can find somebody in your zip code region. We do have practitioners all over the country. I think these slides are going to be shared. John had mentioned that they were going to be put on the site for tomorrow, and he can talk more about that. Another question is, sorry for coming in late, so I don't know if you've addressed this yet or not, but I'm wondering if you have any experience with an opinion of IMT, Integrated Manual Therapy, developed by Sharon Giamato. If you addressed this earlier, no need to repeat. I'll watch the recording when it's posted. You know, I'm familiar a little bit with Sharon's work. I don't think I would be the best person to comment. She has another form of manual therapy where she's addressing the nervous system and the fascial system. From my memory, it's quite light, and I think any of those techniques that, again, are three-dimensional and working with the nervous system and the fascial system together in a very individualized way can be very, very helpful. Where does one start in getting help? EDS patients with pelvic floor dysfunction. I've tried PT with a pelvic floor specialist, but not making any progress after 3 months. I'm feeling with so few resources being available. Well, the pelvic floor is actually, again, part of the body that needs to be looked at in its global perspective. So the pelvic floor is connected to what's called the deep front line, and that deep front line is connected to the adductors on the inside of the legs, down through the posterior tibialis in the lower legs, and down into the intrinsics of the feet. And then above the pelvic floor, it's connected to the psoas and the quadratus lumborum, very strong postural muscles in the thorax connecting to the lumbar spine. And then up into the respiratory diaphragm, up through the inside of the chest wall, and then up through the neck into the jaw, and then up into the brain. So I look at pelvic floor issues as a kind of central core issue all the way through the system. And often what I'll do is I'll work not only with the structures around the pelvic floor, but I'll work above and below that to try to create less tension within the system and alignment of the whole pelvic bowl to make sure that people can then start to use muscles in the correct way. So I would look for a practitioner that is not just working on the pelvic floor itself, but that can look at you a little bit more globally and three-dimensionally. Another comment, you hit the nail on the head. After each of my knee replacements, my pain moved to my hips, and the core strength rehab was needed to bring the whole into 3D alignment. Feeling better than 10 years ago, but hit a wall of tendinitis from overstressing my hamstrings and PT. Yeah, it's kind of hard, isn't it? Sometimes it's 2 steps forward, 1 step back. Again, I see a lot of overstressed hamstrings because there's rotations in the connective tissues around the hips. So getting the alignment correct, then doing some stretching and strengthening can be helpful, but not putting the cart before the horse and doing too much stretching or strengthening without alignment first. Do you think massage chairs can be beneficial? You know, I love any form of soft tissue massage, just so your system likes it back. I think anything that's going to calm your nervous system and get a little bit of mobility through the connective tissue can be helpful. But again, we have to look at the bigger picture of overall postural positioning. So they can be helpful in the short term, but there also needs to be long-term postural retraining as well. Why do extreme temperatures cause more pain? Example, I can no longer handle hot tubs, hot springs, or being in the lake when it's partially melted. I used to do all of these things. Well, often what happens is there starts to become either peripheral or central sensitization in the system where the nerve endings start to become a little more hyper-irritated. And so these nerve endings are called nociceptors, and there can start to be some overflow of the nociceptors and the other receptors in the system. So hypersensitivity can occur because of that. One of the interesting studies that I've seen recently talked about the role of proprioception and focusing on proprioception, meaning where our body is in space and feeling sensations in our body as a way to work with pain modulation and pain reduction. And so I would recommend that the more focus that can be placed on exercises that are going to focus on body scanning around sensations or feeling different sensations that are pleasurable are going to facilitate a calming of the nervous system and hopefully more of a regulation of over-responsive pain receptors. Can you address how to treat stretch injuries to muscles and nerves? Again, you know, I think we have always thought of things getting overstretched and it's the muscles or the nerves, but we're really starting to understand a lot of it has to do with the fascial tissue itself. And so, again, how to avoid overstretching or compression into joints themselves. It's about three-dimensionally balancing the agonist and antagonist muscles as well as the connective tissue around them. So I always recommend that we try to avoid end ranges of motion, especially with resistance, because of the changes in collagen with EDS and the ability to overextend so easily. But starting in an arc of motion that's going to be a lot safer and without resistance initially, and then gently adding a little bit of resistance as able. But you do have to be quite careful, and it, again, can be really helpful to have a provider who's familiar with this work or work similar to be able to guide you on what's non-compensated safe range of motion versus unsafe compensatory patterns. I would definitely be interested in attending any training sessions you have on the East Coast in the main area. How can you get contact information? Cynthia, you can contact me at kellyclancy@balanceot.com, and maybe John or Deanna can put that contact information up on the site. But I'm happy if you know, you invite me to come out and can get a class, and I'd be happy to come out your way. I have breathing problems when the outside temperature falls below freezing. Is there any kind of therapy I can do to help this to be more tolerable? So scientifically, how would you explain what is happening? Well, I'm not a pulmonologist. I'm actually married to a pulmonologist, but I don't know if I could tell you the physiology regarding the alveoli lungs and how that changes, especially related to EDS. But so I don't know if I could really give you any specific recommendations other than I do know that the more we're able to create three-dimensional expansion through the rib cage, and the more that we can allow the rib cage to be able to get a full breath by not just moving in one plane of motion, but all three planes of motion, it's going to help with the lung volume and the lung functioning. So any exercises or practices that you can do that would help encourage more three-dimensional breathing through the top of the lung, or through the top of the thorax, the bottom of the thorax, from the sides with breathing. There's lots of different breathing exercises that are out there and available. Because EDS is chronic, what is the best way to stay on top of things without spending a ton of money? Do you recommend regular PT and OT forever, or can there be ways to maintain without going to OT and PT? You know, Cynthia, I'm always very interested in getting people on a self-care strategies that aren't going to involve healthcare providers always being involved. So, again, what we offer at our clinic is we have what's called a community Bowen work clinic, and it's modeled after community acupuncture, where we set it up on the weekends and we just have a bunch of tables laid out, and it's by donation, and you can just pay as you can. Something like that can be a really nice, low-cost way of maintaining tissue tension three-dimensionally through the system, and or practicing strategies that are going to be movement-based, like classes, specific classes that you can go to, or self-care practices that you're incorporating every day in your day-to-day that is going to help facilitate your nervous system being balanced and your musculoskeletal system being balanced. So with any of us, I think it's really important to practice good self-care, and that involves daily movement of some sort. It involves hydration. It involves getting the right kind of sleep, the right kind of nutrient foods, and also having joy and creativity in our life and diminishing any kinds of negative stressors. So all of those can be really excellent maintenance for long-term conditions. Woo, I think I got through them all. So again,
Wonderful.
Thank you so much for inviting me.
Oh, great, Kelly. Thank you so much. We're getting a lot of great feedback from the live attendees that they're, really digesting the information and really relating to what you're saying and saying, wow, that makes sense. So we really thank you for just unwrapping the mystery of the fascial system, if you will, and just giving all this practical advice. I'm just excited to share this with my providers, and everyone else is indicating the same thing. So hopefully we're on a path to getting more better therapies for everybody. So is there anything else that you'd like to share in closing?
I don't think so. And like I said, feel free to go. I've got a Facebook page at the Seattle Center for Structural Medicine. You can access information there. I also have a school website called the Northwest School of Structural Therapy, and you can find out information there. I am happy to come teach classes if we have enough individuals anywhere in the country, because I feel quite passionate about this information, and would be happy to teach providers in your community. So thank you again for having me.
Thank you, Kelly. And we will provide Kelly's contact information on the same announcement page that you used to log into the live session, as well as her contact information at the end of the slides, which will be loaded as a PDF file for you along with the video. So just a reminder that our next webinar will be on December 15. Don't miss that. Dr. Petra Klinge will be talking about tethered cord syndrome. She was a speaker at the last EDNF conference and is just wonderful in this field of she's a neurosurgeon and just very knowledgeable about EDS. So make sure you don't miss that.
Well, again, thank you, Kelly, and we really appreciate this information. It's the first time that we've been able to approach facet, and I think it'll be something that we can share with, like Dee was saying, with practitioners. And thank you all for attending this evening, and we appreciate you being here. Share this information with others. The recording and the slides will be posted on that announcement page that you used to come in here sometime tomorrow. And please share that. Plus, we have other webinars on our site, so you might find something else that you would find of interest, particularly many with physical therapists. So, again, I want to remind you that these programs are all free, and because we have a store, it's called bodysupportstore.com, where there's over 250 products that were selected by EDSers for EDSers. So that basically pays for our webinar costs. So please go out and visit the store, buy something for the holidays, for Christmas, for a friend, and we'd like to invite you back for our next webinar. So again, thank you, and we're going to close up for this evening. So have a good evening. Thank you.
Good night, everyone.